Welcome back, students, to Part 112 of our Inpatient DRG Masterclass. Today, we're transitioning from our medical deep dive right into the fascinating surgical side of Major Diagnostic Category 18, covering infectious and parasitic diseases. We've got a lot of highly technical, absolutely crucial ground to cover today. But before we jump in, a quick reminder, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Herschel. Let's get to it. Here's our agenda for today's explainer: surgical partitioning logic, high-volume MDC 18 DRGs, PCS precision and root operations, and finally, audit defense. Kicking things off with Section 1, surgical partitioning logic in MDC 18. So how does this actually work? Well, the MSDRG system first looks at your principal diagnosis, say a medical systemic infection. But if a qualifying operating room procedure is performed, that procedure will fundamentally override the medical diagnosis. This override is literally the difference between a standard medical stay and a highly resourced complex surgical case. Now keep in mind, this doesn't apply to everything. Mere bedside ancillary tests, standard lab work, imaging, simple bedside drainage, those aren't going to drive these surgical DRGs. We're looking for major operative interventions here. Think along the lines of deep abscess drainage in the OR or the complex removal of infected cardiac devices. Moving right along to Section 2, high-volume surgical MDC 18 DRGs. We essentially have two major surgical tracks in MDC 18. On one track, we have MSDRGs 856 through 858. These are for post-op and systemic infections paired with an OR procedure. On the other side, MSDRGs 862 to 863 capture other infectious disease OR procedures, like an exploratory laparotomy to track down the source of an infection. These families capture a really wide spectrum of surgical source control. We're talking about everything from debriding, necrotizing systemic infections, all the way to the physical extraction of an infected central venous catheter or PICC line directly in the OR. The key question you always have to ask is, does the procedure actually match the severity of the infection? That brings us to Section 3, PCS precision and root operations. This is where you really separate yourself as a true expert by thinking like a detective. First up, do not confuse these two intent-based root operations. In coding, intent is everything, right? By definition, drainage is taking or letting out fluids or gases, like draining an abscess. Extirpation, on the flip side, is cutting out solid matter, like a thrombus, where the body part itself isn't the primary focus of the procedure. Similarly, we have got to be incredibly precise here. Excision means cutting out a portion of a body part without replacement. Resection means cutting out all of a body part. Never ever assume which one it is just based on a physician scribbling -actomy on a chart. We all know doctors can be a bit creative with their suffixes. You absolutely must read the operative report to verify the true intent. For example, a percutaneous core liver biopsy is coded as an excision, not an extraction or drainage. Why is that? Well, because the larger bore needle actually acts to cut a core of solid tissue right from the body part. Now, here's a critical insider tip for you. Be highly suspicious of physician verbiage. Taking out an infected vascular catheter is a removal in PCS, simply because it's a device. But if a physician documents the removal of a thumbnail, that's actually an extraction. You're pulling out a body part by force. The terminology must map to the PCS definition, not just the doctor's shorthand. To secure the correct surgical DRG, your PCS code must accurately reflect the body system, the approach qualifier, and the depth precision. You have to separate superficial procedures in the subcutaneous tissue from true deep tissue interventions in the general anatomical regions. The approach completely alters your 7-character code. Literally one wrong character and your entire DRG assignment is derailed. Let's jump into Section 4, Audit Defense and CC/MCC Capture. Defending your severity level requires an aggressive clinical documentation improvement strategy. You really need to capture high-yield secondary complications and comorbidities, or major CCs, like septic shock, ARDS, or acute tubular necrosis. Catching these diagnoses drastically shifts the DRG weight and accurately reflects the immense resources required to treat these truly critical patients. We also must meticulously track present on admission, or POA indicators. If a major CC like an acute DVT develops after admission, it gets a POA of N. This makes it a hospital-acquired condition, or HAC, which triggers a payment penalty and a quality review rather than a reimbursement boost. Always, Always verify the exact instrument used in the procedure and definitively confirm whether deep tissue was actually removed. This is what proves that an operating room setting was a medical necessity over standard bedside care. When commercial auditors try to downgrade your stays, this exact data is how you fight back. If the documentation is vague, issue a query. A concurrent query happens while the patient is still hospitalized, while a retrospective query happens after discharge. Either way, clarifying the anatomical site and the surgical intent before final billing is absolutely essential. Leaving it to chance, that's just an automatic compliance risk. Finally, Section 5, Summary and Teaser. The absolute core takeaway here is that a systemic infection, when paired with a precisely documented, qualifying OR root operation, completely transforms the claim. When that is supported by validated secondary conditions like septic shock, it yields a defensible, highly accurate surgical DRG that truly reflects your patient's severity of illness. And that concludes Part 112. You have officially mastered MDC 18. But get ready to pivot your thinking entirely for our next explainer, where we tackle Part 113 and dive into MDC 19, focusing on the incredibly unique challenges of mental diseases and disorders. To finish up, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Keep learning, keep querying, and ask yourself, if an auditor reviewed your surgical infection claims right now, would your documentation hold up? I'll see you in the next lesson to keep building that defense.